Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and Med Talks, I welcome you all to yet another episode of 52 weeks of Diabetes Essentials with Dr. Sanjay Kalra, Season 3. And today's topic is reducing cardiovascular risk in diabetes. Today's session is brought to you by your zero calorie hydration partner, Enerzal Zero. Now, before moving forward to our session, I would like to announce the last week winners. The list is long, so just bear with me. Dr. Gangadhar Rath from Bhubaneswar, Odisha, Dr. Vinay Desai from Thane, Maharashtra, Dr. Bharat Praveen Mittakota from Surat, Gujarat, Dr. Pradeep Patro from Chhatarpur, Odisha, Dr. Rakesh Bhargav from Delhi, Dr. Javed Ahmed from Lucknow, Dr. Shashi Khare from Bhopal, Dr. Karpa Gavalli T from Coimbatore, Dr. Rajiv Handa from Delhi, Dr. Pramod Umraji from Pune, Dr. A.R. Pathan from Kota, Dr. Shashikant Shende from Mumbai, Dr. Satish Kumar Jain from Bangalore, Dr. Ramesh Hegde from Bangalore, Dr. Ravi Bhatt from Sirsi, Dr. M.R. Chipa from Badmer, Dr. Anand Purande from Mumbai, and Dr. Sanjeev Puri from Hoshiarpur. So I would like to thank all the doctors to take part in our quiz. So thank you so much. Now, to enlighten us on today's topic, I would like to welcome our host, Dr. Sanjay Kalra, President, South Asian Federation of Endocrine Society. Over to you, sir.
Thank you, Ankur, and a warm greeting to everyone. Uh, this is our third season of Diabetes Essentials, and we speak about different aspects of diabetes. Today, we'll be speaking about how to prevent cardiovascular risk. If you remember, last time we had spoken about how to prevent cerebrovascular risk. Now, the cerebrovascular bed is one out of many beds in the human body. We divide, just for convenience, we divide the vascular bed into macro and microvascular. There is a slight difference between the etiopathogenesis of microvascular disease and macrovascular dysfunction. There is also a slight difference between what goes on in different macrovascular beds. Today, let's talk about macrovascular beds in general. We use the word cardiovascular. That means we are focusing on the heart as well as upon the other vessels of the body. So allow me to share my slides. And I think the slides should be visible now. Are they, Ankur? Now, what is the aim of type 2 diabetes management? Of course, at a very simple level, the aim is to keep the patient happy, to ensure well-being, to prevent symptoms, right? So you want to prevent osmotic symptoms, you want to prevent other symptoms. This is relatively easily done, relatively. But the aim of good diabetes management is to prevent long-term complications as well. We want to give good quality control today, good quality care today, so that the patient doesn't develop complications later on as well. Many patients will ask you, many doctors will ask you, why do we have to do this? I've got the glucose down. I mean, even if the glucose doesn't come down, I am feeling happy. Why should I bother? The answer is that whatever hyperglycemia there is, whatever glucose levels there are in the ambient circulation, they circulate throughout the body. They circulate in the blood vessels. The blood vessels are lined by endothelium. And these high levels of glucose, also variable glucose, they act as a toxin or as a poison upon the endothelium. This endothelium is ubiquitous all the way from head to toe in each and every vascular bed. And the longer the exposure to high glucose, the more the chances of endothelial dysfunction, endothelial damage. We want to ensure good health today, and we also want to ensure good health tomorrow. We want to ensure sustainable health for the person with type 2 diabetes. And that is why we have to reduce cardiovascular risk. It is not enough just to control glucose. First of all, you have to control glucose in the right manner with the right drugs. Secondly, you have to manage other aspects of endothelial dysfunction as well. And all that is important because we want to prevent CV disease. CV disease is the main cause of death amongst persons with type 2 diabetes. The main diseases are ischemic heart disease, cerebrovascular disease, that is stroke. Stroke can be ischemic or hemorrhagic. We discussed that last week. peripheral arterial disease. You can have peripheral arterial disease anywhere in the body, right? But the main beds which are affected in diabetes are the femoral arterial bed, the feet, and also to an extent the pudendal arterial bed that leads to neuropathy, which is associated with neuropathy that leads to erectile dysfunction or sexual dysfunction. Apart from ischemic heart disease or coronary artery disease, you can also have heart failure. Heart failure can be ischemic or non-ischemic in origin, and this is clubbed with cardiovascular disease for our discussion. CV disease is the cause of death in about 80% of all people with type 2 diabetes, and 80%, and in more than 50% of them, it is easily avoidable. You can easily prevent or postpone this disease. Like we said, multiple factors lead to cardiovascular disease. The underlying factor is endothelial dysfunction. Endothelial dysfunction is promoted by hyperglycemia directly, by oxidative stress, by epigenetic phenomena, and also by dyslipidemia and high blood pressure. So, how do you manage? First of all, we have to speak of what we call health equity or pharmacoequity. Health equity means that each and every person, each and every population should get equitable treatment, irrespective of caste, creed, gender, economic status. Pharmacoequity means that each and every person should get the same pharmacological therapy. This may be difficult to do, difficult to achieve in a pay from pocket market, but we should still strive for that. There are, however, various social determinants of health which prevent us from doing this. Social determinants of health would include the person's or the family's or the community's literacy, numeracy, emotions and attitudes towards healthcare, financial well-being, and also the community's approach towards modern healthcare. Do they accept it or do they dislike it? Still, in spite of all these things, we should continue advocating for CV risk reduction, and we should be able to screen all patients with diabetes for CV risk factors. We should be able to offer good lipid control, blood pressure control, 1 lipids, 2 blood pressure, 3 glucose control, 4 weight management, and 5 antithrombotic management if required. So 5 things that have to be done: diabetes or dysglycemia, high blood pressure, obesity, lipids, and antithrombotic therapy. And along with all these, lifestyle management is required for all. So let's repeat again what we can do. Lifestyle management: a healthy lifestyle including physical activity and nutrition, glucose control, lipids, weight, blood pressure, and antithrombotic therapy if required. In lifestyle management, do not forget the importance of stopping smoking. Smoking cessation is mandatory. Now, when we speak of glucose control, we can use various drugs, but the drugs of choice are metformin, SGLT2 inhibitors, and GLP-1RA. We will speak more about these. Another drug that you can use specifically for preventing stroke in persons with prediabetes is pioglitazone. So another drug with good effects. Acarbose is also useful. It is proven, backed by evidence by the Stop Needham trial. It reduces severe outcomes in persons with prediabetes. So pioglitazone and acarbose also have their place in therapy. Metformin, SGLT2 inhibitors, and GLP-1 agonists are the ones that we use. This is because there are multiple studies to show that the long-acting or the intermediate-acting GLP-1RA and all the SGLT2 inhibitors are either uh, beneficial or safe for heart disease. Recommendations from various guidelines, what do they say? In ADA says that in persons with type 2 diabetes and established ASCVD or multiple risk factors, in persons with established kidney disease, again choose SGLT2 inhibitor and or GLP-1RA. In persons, however, with established heart failure with restricted ejection fraction, prefer SGLT2 inhibitor alone. In those with stable heart failure, you can start metformin. Similar suggestions from European Society of Cardiology and EASD. The European Society for Cardiology says that in persons with type 2 diabetes and ASCVD, you can give metformin. You can also give SGLT2 inhibitor or GLP-1RA. And the American Heart Association says that they are consistent with current ADA guidelines. GLP-1RA work in various ways. They act upon the hypothalamus to reduce appetite. They also modulate the autonomic nervous system, though they increase sympathetic activity, and they may be associated with an increase in resting pulse rate of 2 or 3 per minute. They help in burning the adipose tissue. They reduce inflammation in the adipose tissue. GLP-1RA also lead to natriuresis and reduce the preload. They act on the intestines to reduce absorption of food, to delay gastric emptying. They act upon the pancreas to de-stress the islet of Langerhans. Through all these mechanisms, and directly as well, they act upon the myocardium to make the myocardiocytes more efficient. They increase the glucose utilization of the myocardium, make them more efficient, and try to increase the LV ejection fraction and also reduce infarct size in acute patients. SGLT2 inhibitors also work on various aspects of biology, similar as compared to GLP-1RA, except that they do not work on the hypothalamus. They do not reduce appetite. But otherwise, they reduce blood pressure, they reduce afterload and preload both. They reduce albuminuria and uric acid. They reduce sympathetic nervous system activity. So this is how they are different from GLP-1RA. They also help in reducing weight, just like the GLP-1RA. And apart from that, they de-stress the islet of Langerhans as well. One difference is that SGLT2 inhibitors reduce the need for endogenous insulin secretion, while GLP-1RA are indirectly acting secretagogues. They increase endogenous insulin. If you want the best of both worlds, both can be given together. There is no harm in starting SGLT2 inhibitor and GLP-1RA simultaneously. If the glucose levels are very high, maybe above 8.5 or 9, you can always start simultaneous SGLT2 inhibitor and GLP-1RA over and on top of metformin. Most of us, however, will prefer sequential therapy. So you can start one first. If you are not able to achieve good control, or you want more CV risk reduction, you want more CV safety, CV protection, then you can start the other one. This will be sequential. So one is simultaneous, the other one is sequential. In between, we have swift sequential. So at 1 or 2 or 4 weeks intervals also, you can start the second drug without waiting to look for HbA1c reduction. The reason for swift sequential is that we want better CV protection. So with this brief discussion, let's move on to our questions for today. 2 quiz questions. Let's see the first one. Now, which of these is an accurate statement about CV disease and type 2 diabetes? A. Men have a higher risk of coronary heart disease than women with diabetes. Men with diabetes are at greater risk of coronary artery disease than women with diabetes. B. Early onset type 2 diabetes with multiple coronary risk factors. Early onset type 2 diabetes with multiple CV risk factors is a CHD risk equivalent. C. The risk of CVD is not influenced by fasting plasma glucose. CV risk is not influenced by fasting plasma glucose. And D. Pre-diabetic glucose elevations do not raise the risk of CV disease. So pre-diabetes does not raise the risk of CV disease. Which of these is most accurate? Men versus women, early onset T2D with multiple CV risk factors, CV disease and lack of influence of fasting glucose, and CV disease and lack of interaction or lack of association with pre-diabetes. Quiz question 2. Now, which of these is recognized and accepted method to lower the risk of CV diabetes? So, which is correct? A. Persons with type 2 diabetes are not advised to use high-intensity statins. Okay. Is this correct or is it wrong? B. Advising T2 diabetes patients to reduce triglycerides with pharmacological therapy. C. treat hypertension, maintain a BP less than 130 by 80. And D, treat individuals with 10-year CVD risk of 20% or more with a combination of maximally tolerated statin and additional lipid and cholesterol lowering therapy. Okay, so let's see which is recognized and accepted. A, do not use high intensity statins. B, use pharmacology to reduce triglycerides. C, treat blood pressure, maintain a BP less than 130 by 80. And D, treat individuals with a CV risk of 20% or more over 10 years with combination of maximally tolerated statin and additional therapy. So which of these do you think is the most recognized and accepted? Only one of these is right. With this, let's come to our questions for today. Thanks everyone for logging in. And warm greetings to Dr. A.R. Pathan, who is ex-HOD, Department of Medicine, Kota Medical College. Sir is a great teacher and we are always inspired by his example. Many questions. Let me take them one by one. Okay, Dr. Manjula Devi Vasudev, not able to answer the questions, though she could see the question and the options. Team FDC, could you reach out to Madam? Madam, if you could share your number on the in the chat box, someone from the FDC team will be in touch with you immediately. Or if you can share your city as well, that should also suffice. Now, how do we treat depression in a person with diabetes? Allow us, Jenna, to take that separately because that is a long discussion. I would strongly suggest that you just learn one or two drugs in each category. So for depression, maybe my favorite would be escitalopram, and also a very old combination of flupentixol and mellitracin. Warm greetings to Dr. Anshul from Chhattisgarh. And treating gingivitis also, Jenna, please allow us to take that separately in a general OPD. Can we use ezetimibe plus statin? Yes, we can. In moderately high cholesterol, or should we prefer high dose? So moderate dose intensity should be given to all persons with diabetes. All moderate dose statin, moderate intensity statin should be given to all. If we are not able to achieve target, that is either 30% lowering of baseline LDL or an LDL less than 70 in a high risk patient, an LDL less than 55 in a very high risk patient, then we can add a ezetimibe. Now, both options are correct. You jump from rosuvastatin 20 to 40, or you jump from rosuvastatin 20 to rosuvastatin 20 plus ezetimibe 10. Other discussion, atorva 40 to atorva 80, or atorva 40 to atorva 40 plus ezetimibe 10. Both are right, it is up to you. In general, if your patient is complaining of aches and pains, you are worried about myositis or myalgia, myositis will be very, very rare, but myalgia is fairly common, then add ezetimibe. If your patient is not complaining and says they are fine, then we can double the statin. Warm greetings to Meena Inam from Pakistan. Welcome. And to Dr. Vinayak Sharma as well. And now a question is clinical implications of Q risk 3 score. This is very important. Q risk 3, capital Q, capital R, ISK 3, comes from the United Kingdom. UK is a multi-ethnic country. And what you can do, you can go there, you can type in the details, whatever you know, and you can also type in ethnicity, Bangladeshi, Pakistani, Indian. They go up till that level. You put in whatever you know, and you get your risk for cardiovascular disease over the next 5 or 10 years. If you already have cardiovascular disease, somebody already has established ASCVD, then the risk is of no value. There is already ASCVD. You have to give lipid lowering drug. You have to give antiplatelet drug. You have to treat as per the patient's clinical picture. The main aim of CURIS 3 is to tell patients without ASCVD what risk they are at of. And then if you need to motivate them to take statins, to take insulin, to take better care of their blood pressure or their weight, then CURIS 3 is a very good score to have. It is free to use. And like I said, you can use it for your specific country. So this is something I would recommend using in the OPD. Why is trimetazidine used in cardiac patients? Because it actually improves the efficiency of the myocardiocytes. So it is a good drug to use. It is a good drug for microvascular angina. The patient doesn't have any macrovascular block. Still there is angina. There is ischemic cardiomyopathy. The muscles are not moving properly. There is angina. Then trimetazidine is a good drug to use. When is heparin used? Only to prevent embolic stroke. So heparin will be used if you have a patient who is at high risk of embolism. Example would be maybe mitral stenosis with atrial fibrillation, mitral regurgitation with atrial fibrillation, patients who have just undergone a complex cardiac surgery. Then we use heparin to keep the blood thin. How do you check whether the blood is thin or not? Because if it becomes very thin, then you get in trouble. You can have bleeding tendency. If it is not effective, if heparin is being given in a very low dose, then also there's no point. So heparin and warfarin, heparin is subcutaneous, warfarin is a tablet. Both are called Goldilocks drugs. They have a very narrow therapeutic index, so you have to be careful while using them. So these are situations where heparin is used. Another situation where heparin is used is in pregnancy, when we want to improve obstetric outcomes and patient is at high risk of coagulation or fetal loss. The aim of heparin is to make sure that enough blood enters the fetal circulation and reaches the baby, reaches the fetus. One question is, should patient continue ranolazine after unstable angina event? I think patient can take. It is safe in diabetic patients, certainly. From a cardiac perspective, I may not be very confident about using it in class NYHA4, but from a diabetes perspective, ranolazine is very safe to use. Thanks also to Dr. Anshul for joining us again. And with these questions, let me see if there's something else in the chat box. With these questions, let's just reinforce. Last week we discussed about cerebrovascular disease, and today we are discussing about vascular disease in general, cardiovascular disease. Do remember that a comprehensive approach is what helps the patient best. You can use the term metabolic karma or cardiokarma to explain this to your patient. Whatever karma, whatever actions you had done in the past, they have caused whatever status of heart disease we have today. But that we can't change. We can change what we are doing today. So if today I begin following a healthy lifestyle, I stop smoking, I begin the right drugs, take care of my BP, glucose, cholesterol, and weight, take antiplatelet drugs if indicated, then I'll be able to improve my cardiokarma over the coming years, over the coming decades. Dr. Vijay Kumar Reddy asks if semaglutide is cost effective. I think the answer is yes. So no health economic study is done in India, but the cost is something like 9,000 rupees a month, and it is able to reduce body weight and manage diabetes at the same time. It is also able to reduce cardiovascular outcomes. So it helps diabetes, it helps the weight, and it helps the heart. That is how it is cost effective. Best is to leave it to your patient to discuss. So you can tell the patient, we have this option, semaglutide, it is a tablet. You have to take it 30 minutes before breakfast, at least 30 to 60 minutes before breakfast, with maximum of 100 ml of water. The cost is roughly 300 rupees a day. That is 9,000 rupees a month. And you can, if you feel like, we can prescribe that. Just talk to the patient, and sometimes patient will come back to you and say, sir, please give me that medicine which you wrote, which you had talked about earlier. Now, this question I'm not able to answer. Patient not responding to ivabradine. We can check the resting pulse. We can also make sure that the patient takes the tablet in front of us. If 5 milligram OD doesn't work, shift to 5 milligram BD. Use the original brand if possible. Usually we don't take the names of brands, but Coralan is the original brand, Coralan, 5 milligram OD or 5 milligram BD. And make sure the patient takes it in front of you. If even that doesn't work, then maybe I would ask for a halter. That is what I would do if I'm sure of compliance. And another thing I can do is then I can stop ivabradine and shift to another beta blocker. Maybe bisoprolol is something I would use. Thank you, Dr. Devraj, for your kind words. Dr. Zularia has joined us, and we look forward to more interaction with you, sir. With this, I'd like to thank everyone for having been part of Diabetes Essentials. It's an ongoing journey. Harshi Dhingraji, I apologize, I am not able to offer online consultation, but it's nice hearing your name because my in-laws are Dhingras. So, greetings. If you can tell us the city where you live, we may be able to help you and tell you the right doctor to show. Because I think, considering the phase of life that you're going through, it would be good if we have and it is early also for age 40, but it is good if we can have an endocrinologist to take care of you. So, Harshiji, if you can tell me the city that you work in, we can suggest the right person right now. I'll wait for your answer before we conclude. Any other topics that you want discussed, please feel free to let us know. Diabetes is an ever evolving science. Every day there is something new to learn. And sometimes you learn new things which are so simple about food, for example, about exercise. And other times you learn new things about the latest drugs. So, Bhatinda is a nice place because AIMS Bhatinda has an endocrinologist, Dr. Shivani is one doctor, and then there is another lady doctor. Just let me find her name, Dr. Gupta. I think she's also in Bhatinda. Barnala doesn't have an endocrinologist, and Dr. Shweta Bansal is in the private sector in Bhatinda. Another person who is nearby is Dr. Atul Dhingra from Sri Ganganagar. So these are people who work in Bhatinda or nearby. And I think, but I'm not sure, Dr. Rakesh Goyal from Ludhiana, he visits Bhatinda once a week. So, Harshiji, if you could show anyone, and the local people are Dr. Shivani at AIMS and Dr. Shweta Bansal, I'm sure they will be able to help you. They will be able to help you for both the things, for pre-diabetes as well as for the other hormonal issues. And like I said, it's a very nice surname that you have. So, warm greetings. So it's once again, it's great being with you. I work in Karnal in Haryana, and last week we were struggling with the rains. Now things are fairly fine, and I hope things are fine for all of you wherever you are in the country. So last question I'll take: metoprolol succinate versus tartrate. This is a bit controversial because the both the preparations will have points in favor of them. In such cases, there was a question about ivabradine and also about metoprolol. I would suggest that you write the originator brand and see what happens. Though all generics are supposed to be the same, there might be a difference. Each person responds differently. So choose the originator brand. Here, the brand name would be Celoken, Celoken. And dengue, certainly we'll do in KK Med Talks, which we do every Monday and Thursday at 7 p.m. So we have already done dengue once earlier with Dr. Suneet Verma from Alchemist Hospital, Panchkula. We'll request him to talk again about dengue during the monsoon season. That will be 7 to 8 p.m. Monday or Thursday. So do watch out. I'd like to thank everyone for having joined us today. This is Diabetes Essentials that's going on. And I'd like to hand the platform back to Team FDC, who have been so kind and gracious to us. For the past 3 years, this team from FDC, led by Mr. Basu, has been working selflessly, tirelessly, to ensure that the message of good diabetes care spreads across the country. Mr. Anand, one last question from Dr. Dolaria: fruits and diabetes. So this is mango season, so let us take that. So, sir, if your patient is in diabetic ketoacidosis or is very sick, then maybe we tell them to stop. But tell them just for a few days until you come back to normal. If your patient is well controlled, encourage them to take fruits. Just a few caveats. Don't take immediately after meal. You can take 1 or 2 hours after meal. You can convert the fruit. Don't take it as a dessert. You can convert it into a minor meal or a snack. 3 hours or 2 hours after the previous meal, 2 or 3 hours before the next meal. Second is, how are you taking the fruit? Take it slowly. So let us say it is mango. You can slice the mango into thin slices, or you can dice it into cubes, and eat them slowly one by one. Take a fork, eat slowly. Another way of making it even slower and tastier is to make a fruit raita. So you can make a raita with the mango. It will be very tasty. Don't put any sugar and just keep on eating slowly. The satiety is increased. What other things can you do with the raita? You just put them in the freezer. So that is raita or curd and mango in it, small pieces, and that becomes an ice cream, or it becomes gelato, actually homemade gelato. That is the Italian word, and your patients will find it very tasty. Another thing is, your patients will feel very happy with you, Dr. Devraj, because they are so upset with life. Everything is stop, stop, stop. And fruits don't have so much of calories as compared to sugar or as compared to ghee. So you can encourage them to take in limit. So I hope we've been able to help you, Dr. Talaria. And Mr. Basu, thank you once again for
Yes.
taking all the trouble to continue Diabetes Essentials.
Thank you, Well. And I would like to, I was listening to the session and I saw some of the questions on pertinent to today's topic were related to GLP-1 RA. And I would like to remind all those today who have joined and probably have missed the session where the principal clinical research investigator, Dr. Giulio Rosentek, was interviewed by Dr. Sanjay Kalra on a one-on-one session. This is there in our archive session as well as in the MedTalks or in the YouTube. You can search MedTalks Dr. Sanjay Kalra and Dr. Giulio Rosentek. You can get that, I would say, the pearl of wisdom of more than 1 hour already available for the benefits of of the doctors who have joined today to look into the details from the horse's mouth of the lead principal lead investigator Dr. Giulio Rosentek on the GLP-1 RS subject. And regarding the second subject which was discussed today was the topic suggestions which has come from one of the attendees was dengue. I would suggest Dr. Kande Kalra because looking into the monsoon water coming down or receding slowly, we are expecting a lot of tropical fevers coming in India, which is starting from dengue to leptospirosis and typhus and typhoid, everything. So I would suggest that from the perspective of diabetes patients and how empirically we can, because they all are overlapping symptoms. If we can plan, because now we can see that after onset of monsoon for 6 to 8 weeks, probably that's the right time where we see that the OPDs are filled with fever and maybe tropical fever would be the right indication where you have to. So I would request Dr. Sanjay Kalra to look into that aspect of including that session in because we are in the right
Time.
horizon of time frame. Yeah, because 6 months, six
Easily.
weeks from the onset of
Yes.
monsoon in India.
Hmm.
With that
Easily we
request,
can.
I would with that request, I would certainly take the opportunity to thank Dr. Sanjay Kalra for continuing this season for the third year. Thank you, sir, and Jai
Thank
Hind
you.
from my end.
Jai Hind.